Hey everybody, this is Erica Meloe and welcome to episode number 41. This is a really good one. I always say they're good, but this is quite interesting. A patient of mine who has an extensive injury history, chief complaint of hip pain, but with and I mean a significantly relevant past injury history when she was younger. So join us as Susan and I really clinically reason through the evaluation, talk about her background and how important past medical history is, important past injuries are, especially for patients who have persistent pain. We really hope you enjoy it. And next week, we're going to have another listener on to discuss one of her complex patients. And so what we're going to do is every quarter have a listener on to sort of present us with their tough to treat patients. And also just a couple of other announcements. Susan's new GI and pelvic floor course is online at Embodia Academy in Canada. So if you just Google Embodia Academy and you look under Susan's name as one of the instructors, you will find her new GI and pelvic floor course. And the second announcement is that my ebook of my Why Do I Hurt is going to be coming out in a week or two. And it's amazing, from you go from a paperback to a digital version, how much things change, so to speak. So hope you enjoy and feel free to reach out if anybody has any questions. All right. Thanks a million. Hey everybody, this is Erica Meloe and Susan Clinton, and welcome to Tough to Treat. How are you, Susan?
I'm good. Happy Valentine's Day, Erica.
Right, happy Valentine's Day. My God, I can't believe it's middle of February.
I know.
I know, I was booking my flights for Graham sessions, and I'm like, February 28th, February 29th, and I'm like, oh, there's no February 29th. It's March 1st and March 2nd. Like all of a sudden, we're into March. It's crazy. Yeah. So time flies. Do you want to want me to get right into it?
Yes.
Okay. So this patient is I don't even know how to describe her. Probably one of the toughest patients I have ever had. And I'm still treating her. I just started. She's probably I think I may have seen her 3 times or 4 times. I'm actually seeing her tomorrow, I think. So her history is very extensive. So what I thought I would do is talk about her history because it's extremely relevant to her presentation and her complaints. So I'm going to go through a little bit and then I'll just stop and ask for your thoughts, and I will get into a little bit of the objective and some treatment. Because I haven't really treated her that much, but her history is really important. So she's a 29-year-old female who was referred to me by somebody I know, another physical therapist out west. And she had many complaints, but her chief issue was right anterior thigh pain and groin pain and a pulling, quote unquote, in her right hamstring. So she felt, I'm just looking through some of the notes, she felt like there was like a lot of hamstring, some TFL pulling, but groin pain and anterior thigh pain on her right hip. She had some low back issues and occasional foot stuff, but that was sort of the most prevalent symptom. Okay, her history goes way back. In high school, she didn't have a ton of injuries except some ankle sprains bilaterally and hamstring pulls. She was a runner, an avid runner, went to college for a running scholarship. She broke her left clavicle in a relay race when she was 15 years old. And throughout high school, she would, quote unquote, pull my hamstrings and sprain my ankles on a regular basis, at least once a year. As I mentioned, she went to college on a scholarship, so she had to run. She's a middle distance runner, mostly cross country and track, okay? So during her sophomore year of college, she had some severe left shoulder and neck pain. She also got sick with mono. And when she had her neck pain and her shoulder pain, the pain was going all the way down to her mid-thoracic spine. She couldn't move her head. Her shoulder was really stiff. with that particular part of her body, she has been doing much better in the past since then. She used to get a lot of flare-ups there, but has not, okay? But that was sort of how I would think everything started, with the ankle sprains, the hamstring pulls, and the multiple injuries with running. When in that sophomore year, she sprained her ankle really bad, and I mean really, and she put it in caps. And she doesn't remember which one. My guess is it probably was the right one, but she doesn't remember. And then after that ankle sprain, she started to feel like her leg dead, like the feeling of a dead leg on her right side. Someone gave her some heel lifts. I'm not sure why, but she said that helped. Then she got plantar fasciitis in the fall of her junior year in college. Okay, you're looking at, I mean, this is just the beginning. Okay, right plantar fasciitis. Then she probably had another ankle sprain. She has a very high pain tolerance, obviously, right? She kept running. I think that, you're on a running scholarship. God forbid you take time off, right? So she'd run a few days, then she'd cross-train, et cetera, et cetera. And so right after the plantar fasciitis, the hip started to bother her in her junior year. Okay, so that was the main issue. So prior to that, it was ankles and, hamstring pulls and, shoulder issues, but nothing with the hip until junior year. And she started feeling, as she started coming out of the blocks, the like a dead leg feeling in her right hip. And it got way worse, and she was cross-training. It just started really getting, her TFL started to bother her. Then there was the hamstring issue. And then I'm going to quote her. She felt like there were pulleys pulling on both sides, like her leg was ripping. So I'm going to tell you one more thing, and then we're going to stop, because it gets better. Okay. So, and then lo and behold, what happens after that? Take a guess. She has a stress fracture in her pubic rami on the right. And I'll do one more thing just to top it all off. She didn't have any imaging. She didn't really want to, because she had to run the nationals, and she couldn't even come out of the blocks. So she lost her scholarship, took 6 weeks off, another 6. The stress fracture pain, quote unquote, was gone, but she still had this right hip TFL hamstring tearing. Then also she had low back, had MRIs, nothing, zero, did not find anything yet. So I've got a bunch more, but you let me know what you think just with this.
This is very interesting. The things that come to mind for me right off the top of the hour here is she a hypermobile individual? Where is she on the Beighton scale? Because this is very typical of somebody that has a lot of hypermobilities. Bone health.
You think?
Stress fractures. I'm starting to think a lot of systemic type things here. With her, mono is significant in here. The history of mono, the history of just these chronic kinds of musculoskeletal issues and problems, that are going on. And it makes me kind of wonder if did you have the opportunity to ask her any questions about menses?
Yes, I'm going to get to that. Yeah, she lost in college for some time.
I'm thinking female athlete triad for sure here.
Yep.
I don't know what her relationship is with food, or if she just was undernourished.
I know, it's funny, that never came up. It's interesting you mentioned that.
Mm-hmm. But there's not, oftentimes you can see systemic things being expressed this way, and nobody ever really thinks to look at them from an autoimmunity type of global lens. So
Yep.
those are some thoughts in the back of my head right away, just based on this very interesting history.
Yeah, I agree. So yeah, the food thing, that's interesting. That did not come up, and I will definitely ask her. And that is, I agree with you, extremely important. She is hypermobile. She did lose her period for probably 5 years.
Ooh. Do you know the ages?
Hang on, it's in here. I think it is. Her history was like 3 pages long. What did she say when she was? I'm just looking here. Oh, yes, her body fat got down to 9% in college, and so she didn't say. She lost the cycle, she said. So I remember her saying 5 years, but I didn't write it down.
Mm-hmm.
Yeah. So After that, she ended up getting another stress fracture in her talus. How do you get a stress fracture in your talus?
Yeah,
I'm like, I've
exactly.
never heard of that. She ended up going to see a chiropractor in college. She did a lot of ART. It helped her, et cetera, with the hip. And then she started having some left plantar fasciitis. Then she ruptured her plantar fascia on her left foot. So it's her right hip. And she started working with the physio out west. And the only thing that really helped the hip was continual massage. But it wasn't always like, massage helped. And then, once again, her symptoms came back and her left neck would flare up occasionally. She had finally got another MRI, which revealed a labral tear. No surprise. In the right hip. She had the surgery with Dr. Philippon in Vail, and he repaired the labrum in February 2015. And according to her, he said the inside of the hip, quote, was very hot and red, and it was the worst he's ever seen. And I'm like, talk about ramping up that nervous system.
Yeah.
And so post-operatively, she still complains of this popping in the hip and the pulling in the hamstring. Feels that her, still the leg is still dead. She always feels like her SI joint, quote unquote, is locked. She ended up getting Botox in her TFL. And I said, God, I didn't realize God, I guess they could Botox anything. So that didn't help too much, to be honest. And post-surgically, her functionality is a lot better. But she didn't run for 6 months, actually, after the surgery. And she was still trying to run competitively. So she tried in 2016, and she just ended up she couldn't do it. So she quit. And she ended up getting so she had a period of stability between 2016 and 2018. And then her medial knee pain started bothering her as she just did a little bit of recreational running. That really went away. It kind of comes and goes. This is her main issue. So even when her hip is not hurting, she feels like the femur is jammed up, quote unquote, into the socket. And just some of the notes I received from some of the other people she's seen, when they work on her neck, for example, or they work on another body part, it makes her better in certain parts of her system, but it makes her worse in other parts of her system. And she also complained when I saw her about burning along the medial adductor, and the tight jeans and the spandex tends to burn through there. If she has sex, it makes her back pain worse. She did see a pelvic women's health therapist when she was out west, and they basically did a lot of internal release, according to her, and which did help the right hip, but it only lasted for probably 24 hours. I'm just finishing up with her subjective. So the biggest thing with her is that one day when the same activity will make her feel fine, or the same treatment, the next day the same activity will make her feel worse. So you could do the same thing, but she reacts differently, and that's the whole pattern. We can't come up with a pattern. I mentioned the body fat, 9%. So the main issue is sitting doesn't make her hip worse, but she said sitting is always a bad idea. She recently moved to New York, which is how I started seeing her. She feels like she's 29 with a 60-year-old body. And she felt that when she was in high school and in college, the running coach really started to bump her mileage to 70 miles a week, and that's what did her in. That's a lot of mileage.
Yep.
And that's the end of the subjective. Like,
yeah,
oh my God.
Yeah, she's seen a lot of practitioners and had a lot of things done to her.
Yeah.
She's chasing. This is your typical chasing pain. She's she's actually lost her locus of control in there somewhere. It sounds like there's a lot of things that went on, probably, with the coaches as well as the healthcare providers and the different things. Again, the things that stand out to me, is the bone health issues, especially at that age when we're supposed to be building our bone bank.
Yep.
She is not building her bone bank right now.
No.
which is not, that's no bueno.
No.
She's having a lot of all of those tissue tears and things like that, which are very interesting as well. She's hypermobile and running. Not that hypermobiles can't run, but for her, it hasn't served her well, particularly that the kind of mileage that she's running.
Yep.
It doesn't surprise me at all that she has a high and tight pelvic floor. Something's got to hold her together, just like the over-recruiting hamstrings and, the over-recruiting back stuff that happens with people sometimes with hypermobility, especially if they're high on the Beighton scale. I think the thing that really is interesting is that nobody's really taken the lens to pull all this together. It sounds like somebody's treated the hip, somebody's treated the neck, somebody's treated the pelvic floor a little bit, and none of it really lasts, which is bringing me back to what is really going on with her systemically that could be one of the huge drivers up there. If she lost body weight all the way down to 9%, it makes me worry about the nutrient-dense food she may or may not be eating. She's not getting nutrients in. Therefore, your gut's not going to be healthy. When your gut isn't healthy, that's going to leave you wide open for autoimmune, things to switch on if you have that tendency. And she may have that tendency. Then, of course, having a big illness like mono happens a lot when I see this kind of deal going on. There usually you can find some sort of big systemic illness that has occurred. And so that is not great for the gut either. And the gut being the immune system, you start ending up with a lot of other problems. The pelvic floor itself, when we're under threat, whatever it is, maybe we're under threat because we feel like we have to run 70 miles, we have to do whatever it is, we're going to lose our scholarship, we're going to, all of this, that, we do know that threat can increase the protective response of the pelvic floor, particularly in females. We have research that points to that. And so that may be why unsuccessfully doing internal releases was helpful somewhat, but didn't really change anything over time.
Yeah.
Because the threat's still there. Right. So we can take away the response to the threat for a little bit, but the threat, if the threat's still there, then the response is going to stay there. And so interestingly, it would, who knows what's running the threat response now? I mean, there's so many pieces and parts that went in. So I'm kind of interested to see where you went next.
Yeah. Well, I was too at the time, trust me. So I said, well, is there any one particular, I knew what her answer was going to be. I said, is there any one particular movement that bothers you? She's like, oh, everything, everything. She goes, sitting is, always not good, but never makes anything worse. And so I said to myself, okay, this girl's got a lot of injury history. So what I did was I just picked this because she wasn't able to really pinpoint an activity that made her worse. So I had her, I looked at her in standing, and I'll show you what I found, but I literally had her do a squat with a bilateral arm lift. I figure I'm getting everything from head to toe when I have her squat and lift her arms to see if there's anything that's out of whack, so to speak, or non-optimal, right? Because I figured she's got arm issues, she's got foot issues, so that's what I did. That's the movement test that I did. In standing, I'll briefly, because I don't necessarily think a lot of these objective findings are highly relevant to her issue, but I will just tell you what she looked like so you can get somewhat of an impression of how, obviously hypermobile, bilateral, hyperextension in her knees, thorax was posteriorly translated, compressed in her upper thorax, in her upper ribs. And so in terms of her center of mass, she was pretty much over on her right leg, and which was her symptomatic side. So her center of mass was to the right. Because she had that clavicle fracture on her left side umpteen years ago, I went up there and I just put my hands on there, and it was elevated, posteriorly rotated. It was like compressed into the SC joint. That was the obvious thing. And I put my hands around the hip, and I saw, obviously you had that sort of right anterior medial hip position. sort of a little bit of a pelvic rotation to the left, which is what you would expect if you have somebody with these types of like a labral tear and labral surgery and with the scar tissue. And then I said, let me go to her feet, because she's had multiple issues with her feet. Both of her feet were extremely rigid. I mean, she was gripping the ground. Like she literally, Susan, I don't know how she got her big toe down, but she did it, because she said to me, I always stand on the outside of my feet, like you're standing and you're moving your feet back and forth. So she's like, I do that all the time. And I'm like, well, how do you get your big toe down? But she did. So they have a very rigid foot type. And she tends to do this all the time with her feet. I'm like, don't do that anymore. So a rigid foot, hyperextended knees, right hip anterior medially, a little bit of a pelvic rotation to the left, elevated clavicle. I mean, you expect it to see this stuff with this girl and her injuries, right? So I did a general listening, just because I wanted to see where my hands were taking me as per all the things I learned in the Barral Institute. And it just took me right down in the spine, like right down her back. I didn't think that was quite helpful. But that's what I found in standing. Do you want me to go on, or do you have any comments about that?
I think you said that she's standing over on the right side.
She's standing over onto her right, correct?
Yeah, and that's the side that's her bothersome side.
Correct.
Yeah, so it's interesting. She's not afraid to weight bear on it.
No.
So I find that interesting, because usually my thought would be, wow, they're probably going to be on the left side, because the right side is the one that has the quote dead leg feeling, or the differences and all of that. But she's actually standing on that side. And I also find it very interesting that you, for whatever reason, just felt like you wanted to go to that left shoulder and see what was going on. And I'm just kind of wondering, it's just, it just always makes me wonder, how did this dominant pattern get set up? And I don't find it surprising at all that her feet are gripping like crazy.
Right.
That doesn't surprise me at all. However, that can feed a lot into, if we can't move through our feet, it's going to make it much more difficult with our, shock attenuation and rotation through the system, as we need to have it moving up through the hips and the back and everything. So if it's being blocked at the hip, if it's being blocked at the foot, did the foot come on because that's just the way it is, or did, is the foot actively blocking the rotation so that they're not rotating through the hip? We'll go back here.
Yeah.
I was talking about the foot. If it doesn't surprise me at all that her feet are gripping. This is not somebody with this kind of pain. Certainly has a lot of grippy feet. Goes along with the pelvic floor that's under threat and gripping too. I'm not sure which came first, whether the feet were rigid, structurally, and that is blocking rotation through the hips and the back, or if they're actively working that way to keep things from moving. What I find interesting is this is a chronic ankle sprainer, chronic ankle sprainer that is living on the outsides of her feet. So that makes me almost think that this is a real structural type of deal going on. That the foot, like the rigidity of the foot, is more of a structural piece, and then she's just it's been on the outside of her feet forever, and and then the ankle sprains have probably driven her to the outside of her feet a lot more.
Right. That's interesting, because the first injury she had was her clavicle, besides the hamstring issues in high school. So that's kind of why I went there. And I said, well, that was sort of, the domino. That was like sort of like you hit the domino and then everything else kind of goes down with it. So, she's obviously able to compensate and adapt somewhat well. I mean, she at least got through running, but she just couldn't adapt consistently, and she tore and pulled her hamstring. So I would agree with you. I think that a lot has to do with her what is the chicken or the egg, the feet. So this is where I'm going to get to. So when I I had her do the squat with the bilateral arm lift. I'm like, yeah, you know, and I also agree, being on the right side of her in center of mass. So, before I forget, this is what I did because she was so complicated. What I like to do, and this is just, I learned this in LJ's class, is that I just look at their net center of mass. I look at where their pelvis is, their thorax, and their head. I just do that. I note it down. And if I do an intervention or after a treatment, I reassess. If that same head over feet, thorax over feet, pelvis, etc. If she's worse, if she's still way to the right or way to the left, I did something's up. Okay, and that will come into play on the second. So when I had her do the squat with the arm lift, I will tell you, I said, you know, I mean, nothing was looking right, but she didn't have any pain. This girl had zero pain when I saw her. So she squatted, her hip didn't really center, her feet were still rigid, her clavicle was being sucked up. I mean, nothing was moving appropriately, but she was functioning. She didn't have any pain. But it was the only movement that I could test the entire body with. That's why I went there. So this is what I did. I ended up going to her foot, because her right foot. So I started, I think we've talked about this a bazillion times on other podcasts. I said, I'm going to just start with the foot. That was one of your first injuries. And I neutralized the foot, you know, distracted the subtalar joint. I did it on both feet. And then I just waited. I said, I don't want to, you know, this girl, I just want to make sure her head's not off to the right and I'm not screwing something up in her thorax that she's going to pass out and faint on me. So I went with the foot and she felt okay. And then I said, just stay there, squat and lift your arms up. She squatted, lifted her arms up, her hips centered beautifully. Okay. And she's like, oh, my hip feels good. And I'm like, didn't it feel good before? She's like, well, it felt the same. Like, so her same is, it feels sucked up. It feels, you know,
it's just what it's always been. Yeah.
So that's her normal. So she's like, oh, it feels better. And I'm looking around and her left clavicle and her shoulder is like much worse. So she's like practically in this, like this significant shoulder elevation on her left side, but her hip feels great. I'm like, well, I can't like let you leave like that, because you're like going to come in with like numbness down your left arm tomorrow, you know? So then, and this is, I mean, because she was so complicated, I said, I just have to go with the obvious here. So I went in and I said, let me just take a look let's see what, you know, decompressing your clavicle does to your hip, because that's your chief complaint. As long as it doesn't make your feet worse. So I went in, I tried to do the similar, decompress her clavicle. She squatted. She goes, yeah, my hip doesn't feel so good. And I'm like, oh, here we go. You know, neutralizing the foot makes the hip better, but makes the left shoulder worse, the clavicle. Working on her clavicle doesn't really do anything makes her hip worse and does nothing for the feet. And that's where I was ending. And I'm like, I didn't have any more time during the eval. So I said, this is going to be a tough one, because I don't want to make her worse in another part of her body. So I'm going to stop there. I'll tell you what I did after the next.
Okay. Yeah, because I find it very interesting that I was also kind of going, gee, do we go to the shoulder first? Do we go to the foot first? Where do we go? And to me, I would have gone to the foot first as well, mainly because that's what I'm seeing, and I'm seeing it on the ground, and I'm putting it together with their history. And, you know, and my thought is, and I love that when you got her to change her feet a little bit, she could move differently. So what we're doing is getting people to explore a different movement pattern and get out of their dominant, you know, postural movement pattern. When somebody's super complex like this, go to the easiest thing you can find first, the most, like our Erica said, the most obvious thing you can find, and just see what happens. Get them to move, have them change whatever it is that they're doing, and just look at the movement again and see if it changes, and see what their symptom expression is to the change. She felt better in her hip. To me, that's a win. Yeah. You know, that's a win. That's a super win. And I'm not sure that you're going to be able to get, I myself would say, let's do this, but let's, you know, watch, you know, let's do it a few times and make sure that you feel comfortable with this And what I want you to do is maybe some stuff to work on. I probably would have given her some stuff to work on standing, to just change her feet posture a little bit, and to understand that she can change her feet posture even with rigid feet. You
Yep.
can still move them and change them somewhat. And so I probably would have just kept the focus there myself going forward. But what did you do?
So she was going back home. She had just moved here. She was going back home and just looking through my notes for the holidays. And whenever I see this presentation, I didn't really want to make her worse for the holidays or do anything that would make her potentially worse. So what I thought, this is why my assessment, and I thought that obviously the right foot, or at least the feet, were a significant contributor to her hip problems. But I felt that she was losing options in her upper thorax and her left shoulder, and that she couldn't really adapt for some reason because of all of her old injuries. And I ended up that visit giving her, I actually did give her some foot stuff, like some release stuff with the foot. But what I also gave her, because I've seen this before, if I have a patient where I am giving them a new movement pattern, giving them a new strategy, but if they're not looking well in another part of their body, whether they're feeling woozy or they're just I felt like she was cocooning in her left side, like she was protecting her left side, although treating her foot made her right hip better. I felt that she couldn't adapt to the release or the neutralization of her subtalar joint, and she was just shutting down on her left side. And I said, my gut was like, you can't just give her footwork, because I think she's going to come back with like nausea and vomiting, because she had in the past with other therapists.
Okay. I think I missed that in the history.
No, yeah. I did not mention that, actually.
Okay.
My bad.
All right. So the visceral reaction to change.
Correct.
A big, strong visceral reaction to change. Okay.
Correct. And that's what she told me. That was her whole thing. Sometimes people would make her worse. Sometimes they'd make her better, and they would do the same thing. So because of that, and because she was not going to be here for a bit, I was like, I just can't do that. So I actually gave her, you're going to die, but I gave her like neural movement. I just gave her movement, I had to, because I was like, that's always like my go-to when I can't figure something out, So on her back, a little bit of, mild nodding of the head, and lower trunk rotation bilaterally, move the arms, decompress the clavicle, up in with your toes, what we've discussed in many podcasts before. That's what I gave her. I had her do just heel slides. I had her do lower trunk rotation, moving the arms, and she actually came back after probably about a month, because I hadn't seen her. She felt better. I was like, I was like kind of shocked, but I think maybe because she was home for the holidays and, things like that, but she did feel better. But I will tell you, so I've seen her 2 more times, and I didn't feel like, she's like, well, I didn't really feel much with the glides. And I'm like, you're not supposed to feel very much. Right. You're supposed to get your nervous system moving, right, and you actually are better. So I checked her center of mass. I checked that, okay? And after I saw her before the holidays, I did check her center of mass and her thorax, and it was better. So she wasn't shifted to the right anymore. She was fairly centered, whether it was from gliding or just being home and being in the woods, who knows? She's still out west. So her center of mass she's pretty centered. Her pelvis was centered. Her thorax was a little left translated still, but her head was centered. So she's pretty centered. And I know people walk around all day long and they're going to say, well, you can have that, and that may be normal for people. Yeah, it can be. But for her, I'm looking at change. She could be standing on her head. I just was looking for a change from what I saw her last, and she was definitely off that right leg when she came back from Christmas.
Yeah, the interesting thing too is the intervention that you explored with her was one that she did to herself that you did not do to her. And so how much of that was important, because everything in her history has been what people have done to her. what they've told her, what they've done. You know, they've hurt me, they've made me worse, they've made me better, they've done, but somebody was doing something, and for the first time you gave her movement to explore and sent her away with it. And you didn't do anything to her. Do you see what I'm saying? I think that's a game changer in the neurological system as well. You gave her some simple things to do. You told her that she could change. You created change by just changing her position of her foot a little bit, so she could see that right away. So she knows, you know, that there's, you know, some, and so the buy-in was there as far as, you know, what she had. And I think that that's super powerful, you know, super powerful, because now she's in control. She's in control of how much or how little she's going to do and how she's going to feel about it. Adding that, that whole visceral reaction really ups the game for me on systemic driver here. I mean, really seriously ups the game for me on that. So, there's a couple of things that come to mind. I don't know if she's already seen a physician for some things, or
I doubt it.
But anyway, she needs to have a full hormone panel run. She does. She went 5 years without her period. Her estrogen is probably in the tank. You know, down too low in the tank for sure. She needs to see somebody about looking at a SED rate, C-reactive proteins, autoimmune markers, a full thyroid panel, not a T3, T4, but the full-blown T3, T4, reverse T3, reverse T4 ratios and antibodies, and antibodies for mono. See if that's still active in her system, because you can have mono and still have active antibodies for a while, and you know, start there. But that needs to be definitely dealt with for her tissues, especially at 29 years of age.
I know.
Not have any estrogen in her system is a huge problem. So I think in that visceral reaction really tells me how labile her immune GI system is. So it really took a beating and a pounding through all of this. And whether it was that way before or if it became that way, again, who knows? But this is not an uncommon thing that I see with people who are just, you know, I see this in triathlete runners as well. You know, just their immune system is just, you know, gone off the charts because they've just you know, this is, part of me wants to almost think this is a problem of overtraining, you know, in those really formative years for her, which is a bit concerning as well too. I mean, you know, because no respect. When you have a stress fracture at that age and your pelvic rim, you know,
I know.
I just, you know, it just begins to really, you know, kind of makes me wonder, you know, about, you know, how healthy her femoral neck really was. You know, on that side too, and certainly the heel. You know, you don't expect it. You could expect it more in the calcaneus and the talus, but shock attenuation for her is not good.
She's tearing tissue.
So, and so, and that's a hormone issue there. You know, and
I agree.
You know, when the hormones are that low, that's a very stressful event to the system.
I agree.
And that's going to, you know, that again, you know, we have to think about other issues such as how healthy is her gut microbiome. You know, I mean, she's been, you know, in trouble for a long time, and it's going to take a little bit more than just, you know, the easy stuff to pull her out. But the movement of the nervous system is so key to this, because, you know, the rotation that you put back into her system, I wonder if anybody ever told her to rotate.
I know.
And the idea that you gave her that lovely movement to do and just explore and just allow her nerves to begin to just glide and slide again. And that she actually felt better. And a combination of she was in control, she was on holiday, you know, and all of that is really good. So I think that's a huge positive. So hopefully she'll be able to be amenable to, you know, listen about, you know, finding a physician that can help her with some of the other stuff. You know, I'm thinking functional medicine doctor primarily, but there's probably other physicians in the New York area that are super that you know of that would be
Yeah.
really good with her.
Yeah, I asked her if she had a primary care, and she said no. And I said, because she just moved here, I said, you need
Yeah.
to get one. And
Mm-hmm.
because there's just way too much. I would highly agree on the hormones and the thyroid. And
Mm-hmm.
I mean
That's
that
just a starting
history.
place. Yeah.
Oh,
Yeah. Just a
I know.
starting place, but start with the most obvious first.
I know.
Right?
Eh,
She didn't have a period for 5 years. It was down to 9% body fat. Let's start with the hormones and the thyroid right away, and the SED
Yeah,
rates and the C-reactive proteins, and see
yeah.
what shows up.
I mean, talk about inflammation. She says she feels like she's a 60-year-old body. I'm
Yeah.
like, she probably does have a 60-year-old body,
Mm-hmm.
you know. And I highly agree. I actually think I am seeing her soon, so I will. I'll press her on that.
Mm-hmm.
You know, and I think so. She came back, and I said, look, her biomechanical issues are, you take them for what they are. They're compensations and adaptations to
Mm-hmm.
every single injury she's had since she was 15 years old.
Mm-hmm.
We can't, as physical therapists, chase every single body part that hurts on her, because that is going to go down the rabbit hole, and I will never
Mm-hmm.
get out of there.
Yeah. Well,
And
and other
neither
people
will
have done
she.
that, right?
Yeah. Yeah. So the one thing that really did help, at least from a musculoskeletal perspective, was working and giving her movement for her right foot and doing the neural glides.
Mm-hmm.
So the last time I saw her, I did work exclusively on her right foot, and I did some soft tissue in a subtalar joint. I did some of the distraction
Mm-hmm.
taping I'd mentioned before. I got her up. She looked pretty. Pelvis was centered. Everything was centered good. And then she had a little bit of a back issue. And I don't like to ignore patients, but with people like this, I just can't hear about their secondary issues, because to me, they're not relevant. I don't think.
Mm-hmm.
You know, I had her do a little bit on the Pilates equipment just to get her started gliding and sliding and things like
Mm-hmm.
that. And I had her move around because I wanted to see within 10 minutes if anything was going to go awry. And
Mm-hmm.
that's why with some of these patients, I don't like run right up to the end of my time. I do something, and then I'll finish the treatment. I'll have them walk around or move, especially with someone as sensitive as her. Like,
Mm-hmm.
she'll walk out the door and she'll be like, I'm back because something else hurts, you know?
Yeah.
But she did not come back. So
Mm-hmm.
she felt pretty good when she left. And that's where I am with her. And haven't done a lot of intervention. I've just done what we've discussed.
Yeah,
And
I agree on that completely. That I think that the key when you get somebody who's very complex like this, it's the global lens that you have to put on and just get the system moving and get them tolerating some different movements and get them, experiencing some different kinds of movements and things that they've never done before.
Yep.
A regional or a joint approach with her is not going to be helpful, I don't think. And the more hands-off as you can be, the better, and like you say, I want her to get, we put some tape on. Tape is a sensory experience. Go walk around for a bit and see how it does,
Mm-hmm,
right?
mm-hmm.
See if your system, is going to change because of it in a positive way.
Yeah.
So you gave her the ability to figure that out.
Yeah.
And so that she can do this, and I think that's the the kind of thing you have to think about is there's plenty of time to deal with if you need to exercise a specific joint or you need to do something, but you got to get the whole system just better first,
Mm-hmm,
and
mm-hmm.
see what emerges from that.
Yep.
Because otherwise you're trying to pull pieces of chicken or pea out of the chicken soup, but the
Mm-hmm.
soup is still there. Instead, change the soup, and see what's left once you change it, see
Exactly.
what shows up. And I think that that's a huge piece here. So when all our listeners out there are kind of thinking, gosh, I wouldn't, what would I do with a case like this? And all of us have them. They walk in the door every day. Just listen to the story, which is what Erica did. She listened. She didn't interrupt her. She didn't, she asked for clarification. She asked some questions, but her basic thing was, tell me more, tell me more,
Mm-hmm.
tell me
Mm-hmm.
everything, tell me the whole story. So she could hear all the scary words that this person was saying, and she could hear her, her history and what troubled her and how things actually helped her or didn't help her in the past. And I think that guided your clinical decision making quite a bit, wouldn't you say? Because you
Yes.
already heard that, when people do this, it didn't get better, or this made me sick, or this whatever.
Mm-hmm.
So right away you can find out, sometimes it's like a kind of clinical reasoning by exclusion. Okay, we won't do that. We won't do that. We won't do that. Okay, what's left?
And it's
and that's
true.
important, because you can get there by understanding what you're not going to do, sometimes faster than trying to think what you are going to do.
Correct. So when I was neutralizing her foot or decompressing her clavicle, I was making sure that she was still breathing.
Yeah,
and
exactly.
that, nothing was getting worse in her thorax that would give her, a sympathetic reaction. Like all of a sudden, is she shrinking and compressing in her thorax, which she was not. But in my experience has been that when one thing with a history like this, irrespective of the history, but if you're doing different things you're trying to modify movement, and nothing you're doing is giving you that bang for your buck, like in our past podcasts, nothing is giving that bang for your buck, right? There's something internally going on with the person, and whether it's, she's got some whether it's systemic, which I agree with you, I think it probably is, or whether it's just, she is just protecting herself. She's protective,
just totally afraid.
Yeah. And that's where she is, because we did one thing, the other part of her body got worse, et cetera, et cetera. But when I saw her, so that is why when I put my hands on people with this kind of a history, I don't start poking around. I just put my hands on them and I just see how they react to my hand placement, because less is more with these people.
Yeah, absolutely. Their system is already under threat. Yeah.
Yep.
So, but I love also turning the locus of control back to the patient, and you did that beautifully. Yeah. And, here's somebody who was sitting in front of you that told you she had given all of her control away, or had let others take it, or had just entered into trying to do the right things for herself. She just encountered people who were going to do things to her, and her belief system was that was kind of how it needed to be, so she's learning a new way now with you, which is just wonderful. Because you're looking at her as a whole person and not your ankles and your knee and your hip. And so I have a hip coming in at 2:00. I have a shoulder coming in at 3.
Right.
It's like, no, you have a person that has pain in their hip coming in at 2:00, and a person that has a problem with their shoulder at 3:00. So, and keeping that in mind can be very helpful when we get these complex patients like this.
Yep.
Because they're looking for answers. They're behaving in a way that they've learned to behave. It's not that they are intending to behave in a bad way. Right. It's ways that they've learned throughout their journey. And so really listening can help them begin to feel like that there's a different way. And I think this really highlighted that brilliantly. Yep. Thank you for sharing this.
No, it's fantastic. I will definitely keep everybody posted, because this is one of my tougher ones in my career. So I love working with these patients. So it's great. And once again, I think as therapists, we treat the whole body, and that means referring out to a doctor when you think there's a hormonal issue. I mean, it's
and finding the right doctor that's going to really help them. Get to the bottom and do the right blood testing and the stuff.
Yeah.
And if everything gets ruled out, fantastic.
Yep.
But this has a lot of signs that need to be, there's reasons medically why she needs to be looked at, for sure.
Yeah, I agree. Well, cool. Hope everybody enjoyed it.
Thank you. Everybody have a great day. Whatever you're doing, may all your endeavors be positive and fruitful. Absolutely. And Erica, I will see you the next time.
Sounds good. Bye.
Okay, bye.